So how do patients present? And this is a really good case. So this is a 55-year-old woman who's referred to your office for abnormal liver tests. She was seen by her PCP, and she had mild fatigue, and she manages a restaurant. She drinks some wine. She doesn't smoke. She's hypothyroid. She's on Synthroid. And her physical exam, she's overweight. Her BMI is 28, and the rest of her exam is unremarkable. Sounds like a patient with maybe MASLD or med-ALD. And for many patients, the workup would really stop there. Here's her labs. She has an elevated AST and ALT, but she does have a cholestatic pattern. Remember that with any liver disease, you can have non-specific elevation of your alk phos, but her alk phos is 3 times the upper limit of normal. Many of these patients would be diagnosed with fatty liver, told to stop drinking, and told to lose weight, and the workup would stop there. But not for us. We're going to do more. So what would you do? You'd get an ultrasound. I would say it probably would have showed a fatty liver and a normal spleen and a gallbladder polyp. And you would have told her she needs an ultrasound in a year for a gallbladder polyp and that she needs to lose weight and not drink. So, but she is a perfect PBC phenotype. She's over age 45. She's a woman. And we haven't checked her AMA and ANA. We haven't checked her immunoglobulins. But she does have a markedly elevated alkaline phosphatase. And the other little brownie and pearl is, don't miss somebody with pancreatic cancer who has an elevated alkaline phosphatase, have a low threshold to get an MRCP. So, most patients will have non-specific symptoms. They may have fatigue. They may have pruritus. The pruritus tends to, if it's PBC-associated pruritus, it's really quite characteristic. It happens at night. It tends to involve the palms and the soles of their feet and often the fronts of their shins. You see a lot of patients who have hyperpigmentation on the front of their shins. It's because they're scratching their leg with their other heel, often when they're sleeping. And so if you see those things, you should think about it. All the other things, they do have hyperlipidemia with a high HDL. And so oftentimes they're not being treated because their HDL is so high. So if I see a woman with pruritus, with hyperlipidemia, with a very high HDL and osteoporosis, think hard about PBC. So, but most common is fatigue and pruritus, and that's the way it goes. But many will be asymptomatic. Very uncommon, and we went through these: Sicca syndrome, hypothyroidism, osteoporosis is due to malabsorption of fat-soluble vitamins. I do measure vitamin A and D. D is often low in everybody, so it's not that helpful, but you should measure it. A, if it's low, means you have to replace all the fat-soluble vitamins. Vitamin A deficiency can lead to night blindness, which is really quite troubling. So any of your cholestatic patients measure vitamin A and D. You can measure vitamin E, but who knows what it does? So if their A is normal, I'm done. If their A is low, I give the pediatric version of ADEC, which is in a lipid emulsified thing that allows them to absorb it. And then the other things are uncommon. I'm not going to talk about them today. But do look for coexisting celiac disease. Now, the symptoms do reduce quality of life, particularly pruritus. Pruritus then impairs sleeping and makes the fatigue worse. There are treatments. I must admit they're not great. These are really, I guess these would be the liver equivalent of bloating, common and hard to manage. So how do we diagnose this? And Paul went through this. If you have an elevated alk phos and a positive AMA, you can stop. You've made the diagnosis. If you have a positive AMA and the alk phos is not that elevated and the AST and ALT are elevated, you should be thinking about an overlap syndrome. And that's when I do the biopsy. So biopsy for diagnosis, but if you have the 2 out of the 3, You don't do the biopsy, you do non-invasive testing for staging. So I don't do a biopsy for staging. I do the biopsy if the diagnosis is unclear. Elevated alkaline phosphatase, normal MRCP, negative AMA, biopsy. So ALK-Phos and AMA, you can use the GP210 and anti-SP100, but my feeling is those are not part of the diagnostic criteria. I do that if I have a biopsy that looks like PBC as a confirmatory test. You need to rule out biliary obstruction. I always say everybody has obstruction till proven otherwise. An ultrasound without dilated ducts is probably okay, but if there's any question, an MRCP. And then some type of non-invasive staging. I tend to use elastography. ELF also works. And as I said, only time to do a liver biopsy is if you think they have an overlap syndrome. So why is it important? It's because treatment makes a difference. If you don't treat, patients will progress, and they can progress at a variable and sometimes rapid rate. And early intervention improves outcome. So ALK-Phos is probably the single most important predictor of progression. Obviously, non-invasive tests will show you progression, but ALK-Phos predicts progression. And the more we've learned about ALK-Phos, the more important it's become, and the more strict our criteria have become in working towards normalization. Very similar to the early days of autoimmune hepatitis, where many of us tolerated mildly abnormal AST and ALT. Now my goal in autoimmune hepatitis is normal ALT, and increasingly my goal in PBC is normal ALK-Phos. And part of the reason we tolerated abnormal ALK-Phos was because we only had one treatment. And if they didn't respond to that, there wasn't much else we could do. But now we have other options. So increased ALK-Phos is associated with more rapid progression. And the converse is lowering ALK-Phos with treatment is associated with a longer transplant-free survival. And I want, if I was a patient, a longer transplant-free survival. So I would want treatment, and I would want the lowest ALK-Phos possible. Bilirubin is obviously also important, but if you wait until the bilirubin's abnormal, you've really missed it. And there is data showing that having a bilirubin of 0.6 is better than having a bilirubin of 1, which many of us would just kind of ignore. But you want the bilirubin to be not only normal, but normal. Since most of us, if we don't have Gilbert's, do have a bilirubin under 1. I have Gilbert's, so mine's over 1. It is what it is. So PBC should be suspected in anyone with a cholestatic liver pattern. The degree of ALK-Phos is associated with the degree of inflammation. And we saw that an ALK-Phos lower than 1.67 times the upper limit of normal, which is about 200, is associated with improved outcome. And now data shows that an ALK-Phos lower than the upper limit of normal is better than 1 to 1.67. So increasingly, my goal is not to get to less than 200, but to get to normal. So you were better. You came to this lecture. You went home. You said, I'm not just going to diagnose you with fatty liver. I'm going to do a complete workup. And you check, and our AMA is 1 to 320. And you say, well, you may have fatty liver too, but you have PBC. She flips out. And then she says, I have been itchy, which always happens after you tell them that they have PBC. And so then what? So the first thing is, it doesn't matter what her stage is. You should stage her. But every patient with PBC should be treated. Period. There's no exception to that rule. If Paul and Paul can come up with one, they can do it during the question and answer, but I don't think they will. So because we know that treatment is better, and our goal is normalize ALK-Phos, bilirubin less than 0.6. So what defines a response? He showed you all these. I would say ignore them. The lower the alk phos, the better, period. And so, yes, if you're a hepatologist, you want to be invited to the Paris conference or maybe Barcelona. If you're a lower level, you have to go to Rochester. But these help for publications, but they're all based on alk phos and they're all arbitrary. And really the goal is get the alk phos as low as you can. And so URSO works. And here you can see that if you have early stage PBC, your survival is no different than the general population. So if you find someone with early stage PBC and you keep them there, you're going to make them better. Because if they get to moderate stage or advanced stage, their survival drops off markedly. And when you start URSO, it works quickly. Generally within a few weeks, certainly by 6 months. The ASLD criteria is you give it a year, but you can consider adding second line therapy as early as 6 months if they've really plateaued at a high level. But generally, for your boards, the answer is you give a year. FYI. So, how does it work? We don't really know. It is a choleratic, and it replaces your bile acid pool from more hydrophobic to more hydrophilic, and that's supposed to be good. But no one really knows the exact mechanism of action, but we do know that it's a different mechanism of action than our newer agents. So they are complementary. They are not one or the other. So most of your patients, if they need second line therapy, it is additive therapy, not swapping. And it does have some adverse effects, mainly GI, mainly when you start. If people have trouble, you can start at a lower dose and ramp up, or give it with food, even though it says not to. And that will reduce your adverse effects. And there is a hair loss. People used to complain about it. I didn't really believe it, but it is true. And it can be troubling to some. About somewhere around 40% are inadequate responders. This doesn't mean non-responders. It means usually they respond, but they don't get to less than 1.67 times the upper limit of normal. It's higher if you define inadequate response as normal. And about 5% are intolerant. And none of the therapies work for fatigue. And only one of the therapies have been shown to work for pruritus, and I'll go into that in a moment. The idea that UDCA, it may make pruritus better in some people, particularly when you first start it, but most it does not. And in some, if they're intensely cholestatic, it can actually make it worse. So what happens when people have an inadequate response? First thing is ask whether they're taking it. Don't use it 3 times a day, twice a day. If the dose is 900, 2 in the morning, 1 at night, or 1 in the morning, 2 at night. I tell all my patients, you just take it twice a day. It doesn't matter how many pills, 2 in the morning, 3 at night. I don't care. Don't avoid TID dosing. Ask them whether they're not taking it because of side effects. Make sure that they're on the right dose, 13 to 15 milligrams. I see so many patients are on 300 BID just because that's the recommended dose in EPIC. And unless you weigh very little, 600 is not enough for many of your patients. Most patients will be on 900 plus. The other thing is, do you have the right diagnosis? Do they have an AIH overlap? Do they need immunosuppression? And if the alk phos has come down, but the ALT is still high, they may need a liver biopsy. And then we talked about if you're using bile acid sequestrants for itch, I say they have to be separated by 4 hours in both directions, which means the bile acid sequestration taken at lunch. So she started on UDCA. She has a FibroScan that has early stage disease. She's taking 1,000, which would either be 2 500s or 4 250s. And she gets a good response, right? Her alk phos goes down from 386 to 246. And her ALT and AST have normalized. And her bilirubin is the same. Still less than 1, but not 0.6. Now what? Old days, just rocked on. Said, okay, it's better. But now we have other therapies, and we have 3 approved second-line therapies. Paul went through these. I'm going to try to highlight something a little different than he did without trying to overlap. So all are approved with the same indication, really. They're approved in combination with urso in adults who have not responded, or as a monotherapy in those that don't tolerate. So in all of the trials, 90% of the patients, it was combination therapy, and about 9%, it was monotherapy. It should not be used in anyone who has decompensated cirrhosis, and this warning actually goes across all 3, but the liver disease strictness has to be higher with obeticholic acid than elafibranor and seladelpar. Though I have patients with compensated cirrhosis who've been on obeticholic acid for quite some time, tolerating it well with normal alk phos, I don't switch them just because of the warning. If they've been doing fine, you can leave them on it. So obeticholic acid was approved in 2016. The POISE trial showed efficacy. The endpoint for all these trials was the same, an alk phos less than 1.67 with a reduction from baseline of at least 15%. The issue with obeticholic acid is largely that a proportion of patients, about 10%, will have markedly worsened pruritus, and that's problematic. The issue is that it is a bile acid, a hydrophobic bile acid, and it works by activating FXR. So it's an FXR agonist. The problem is hydrophobic bile acids accumulate in patients with advanced cirrhosis. So if you're using 5 milligrams a day and the patient has synthetic dysfunction or portal hypertension, you're going to have toxic levels and a problem. So it should be avoided in anyone with portal hypertension or decompensated cirrhosis. So what is the data that supports obeticholic acid other than the POISE trial? And this was a trial that was published, first presented from Gideon Hirschfeld and Toronto, looking at the Komodo Healthcare Database, which is a pharmaceutical database. And they took patients on OCA and found matched controls who had similar alk phos, similar liver disease, and followed them over time. And what you showed was in 431 treated patients compared to 10x matched controls, because very few patients are on obeticholic acid, they showed over a 5-year period a reduction in the need for death or transplant by 0.7%. I mean, 63% reduction. So a hazard ratio of 0.37. So when you normalize alk phos, obeticholic acid works. So PPARs are a second mechanism of action. So we have urso, bile acid, mechanism of action unknown, obeticholic acid, FXR agonist, and then we have 2 PPARs. Now, it's important to know that fibrates, which have been used off-label for PBC, are also, their mechanism of action is as a PPAR, not as a bile acid binding resin. So if you're using fibrates, and they're not working, it's unlikely that switching to another PPAR will help, but maybe. So the difference between elafibranor and seladelpar is elafibranor works on PPAR alpha and delta, and seladelpar only works on delta. What does that mean? I don't know. But you can see that both alpha and delta affect cholestasis, lipids, and inflammation. Delta is more important in fibrosis. Gamma, we don't have an agent for gamma yet. So if we look at the trials, this is elafibranor. Once again, the entry criteria, basically the same as obeticholic acid and the same as Sela, meaning an alk phos over 1.67 times the upper limit of normal with inadequate response to urso or intolerant. And then it was a stratified analysis, Elafibranor versus placebo, 2-1. At the end, there's an open label extension that's going out to 5 years. So we're going to have placebo-controlled data for 2 years and then open label data for 5 years, which is a pretty common study design these days. And what you see is when you look at the composite endpoint of an alk phos less than 1.67 with the decrease, exactly the same as obeticholic acid, 51 versus 4%, normalization in 15% versus 0. So great, about half get what you need, and about 15% get what would be the ideal target, which says to me that we're going to have some patients eventually on triple therapy once it's been shown. And what you see is that the alk phos drops very, very rapidly. This is in weeks. By a month, they're way down. And then if they don't respond, really by 3 months, they probably are not going to respond because you can see it flattens out there. So just like urso, when these work, they work quickly. The adverse events are mainly GI, abdominal pain, diarrhea. That seems to be like the watchword of every drug I talk about. Abdominal pain, diarrhea, and nausea. Well, and obviously, you're all gastroenterologists. You know how to manage that. I'm not going to probably tell you anything you don't know. Generally mild. Most patients do not have to discontinue, but some do. So Seladelpar, exact same trial design, 2-1 randomization between Sela and placebo, except they only did a 1-year study and then put all the patients on open label, and they're going out for years now too. Once again, they stratified based on how their alk phos was, and they were brilliant in that they built in a itch component. So I can't tell you whether elafibranor improves itch or doesn't improve itch. Wasn't measured. But I do know that OCA makes itch worse. Ela is unknown, and Sela, as you'll see, improves itch. So they measured itch with a validated score over time. And what you can see is you know, everybody always likes to look at the numbers and say, oh, the alk phos was high, normalization was higher, but you cannot really make that determination without knowing the baseline and without knowing how many patients were really high and not. But obviously, you can see the placebo rate for the composite endpoint was higher. It's 3x. The effect size about the same. Numerically, it had the highest rate of alk phos normalization at 25%. And if you look, once again, the data is not presented the same way. So for Ela, they presented it as percentage decline. And for Sela, they presented it as numerical decline. So hard to really compare the two. But once again, you see the kinetics are the same. By month 1, rapid drop. By month 3, flat. And obeticholic acid, exact same thing. So for all of the second-line agents, if they haven't responded by month 3, you're not going to get much additional response. Now, here was the key secondary endpoint, was if you look, obviously they told the patients that their itch would get better because the placebo rate of itch getting better was pretty big. I've never treated anyone with anything that's had that marked a response in itch, but a statistically improved itch response with Sela compared to placebo. And that is for patients who have itch going in is definitely a significant benefit. The treatment adverse events numerically were lower than elafibranor, and I don't know how to interpret this. They were lower in both the placebo arm and in the treatment arm, and I don't know whether that's because of how they collected it. But if you look back at the abdominal pain, you can see it's 7% versus 1.5%. I'm always amazed that 1.5% of people had abdominal pain over 12 months. That seems incredibly low. They only probably gave them, abdominal pain. I don't know how they asked to get it down that low. Most of my patients have abdominal pain every week. So, patient goes on a PPAR, and their alk phos after 4 weeks is 145, 28, and here they are. And so you would continue. We could debate whether we have to get lower than 145 a year, but to me, I would say I'd be pretty darn happy at this point. You can see that now our ALT is really even better. It's now down in the 20s, which is where we want it. And then for fatigue, I don't know what to do. For itch, as I said, you can add a bile acid resin, but it has to be separated from the urso. I do think, as Paul highlighted, the IBAT inhibitors have a great potential here, but they're not approved and impossible to get off-label. So, where is our treatment algorithm at the current time? You make your diagnosis, you start everybody on urso. As I said, the ASLD criteria is 1 year to assess response, but you may know as early as 6 months. If they're responding, great. No reason to do anything else. If they're incomplete responding, my feeling is in 2025, we should go straight to a second-line agent. If they're intolerant, you go to a second-line agent as your first-line agent. And that should be rare. So, in summary, alk phos and AMA are sufficient for the diagnosis. You should be biopsying very few. Ultrasound, I disagree that MRCP can give false positive results. I would say a good ultrasound in a thin patient, you're done. If you have no dilated ducts, if the patient is older, has symptoms that are worrisome, I think an MRCP to make sure the pancreas is okay is not a terrible idea. If the ALT is mildly elevated, I don't think you have to think about overlap syndrome, even if the ANA is positive. Your immunoglobulins will be very helpful in that situation. Remember that autoimmune hepatitis gives you a high level of total IgG. Cholestatic diseases give you a high level of IgM. Overlap syndromes will tend to give you both. So if I have a patient with a relatively high IgG and an elevated ALT, that's when I'm going to do a biopsy, because I don't use immunosuppressive therapy without a biopsy. That's pretty much ever. So, but there is no downside if even with a positive ANA of starting urso, because it's a benign medication, and if everything normalizes, including your AST and ALT, you're done. Only if the AST, ALT are very high will I go straight to a biopsy if this looks like PBC. If they don't normalize, I can always biopsy them later. Symptoms are an important part. I'm looking forward to when IBAT inhibitors are approved for PBC and PSC. In the meantime, you have to use the things you have. You can use rifampin, you can use a bile acid binding resin. The thing I would say doesn't work very well is antihistamines, and they're the most commonly used. If I'm using something at night, I tend to use doxepin. And then really those that have advanced liver disease should be sent to a transplant center, but most of this can be managed in a GI practice, with the biggest hassle getting approval for second-line therapy.